Okay, thank you. Okay, so today's tutoring session is going to be focused on chapters 18, 19, and 20, so everything cardiac related. Just keep in mind that on Blackboard, I do have the uploaded PowerPoints and videos. I am updating my videos as far as my lecture videos are concerned. So if you are already subscribed to the YouTube channel, you'll notice that I just uploaded 16 yesterday, so there's an updated version of 16. However, I will be recording the rest, and I will be packaging it in a different format. So I have an idea of a different layout that's going to be really better for you guys to like kind of deliver the information. So you know, just kind of sit tight. It's coming in the next 2 days, okay? But however, if you want to get started, which is kind of looking at the updated version, then it's there. So for this tutoring session, we're going to focus on going over the concepts that are really important for these chapters. Also, I'm going to show you how to break down this information as far as like how to package it, how to package the information when you're studying these topics, okay? So we want to make sure that we're able to, you know, not memorize slide by slide, but just have a full understanding, like the big picture, okay? So for chapter 16, this chapter focuses on alterations of blood pressure, okay? So in this chapter, we're actually going into everything about hypertension. So the first half of this chapter is focused on the normal anatomy and physiology of how blood pressure is regulated in the body. So we're going to go over that first. And then the second half goes into the term, or I should say the topic of hypertension, okay? So I wrote a few concepts here on the board that I want to go into detail with. And so for chapter 16, we start off explaining what is considered arterial blood pressure, okay? Now, I think we have an idea from anatomy and physiology that blood in an artery, okay, actually will take this blood everywhere systemically to the body, okay, especially if we're talking about left-sided circulation or systemic circulation. So when we're measuring blood pressure, we want to be able to measure blood pressure not only just in one area for a patient, but we want to be able to measure blood pressure systemically in the entire body to understand the big picture here, okay? So this is why we actually measure the blood pressure in an artery, obviously, and not in a vein, okay? Now, there are a few concepts, and also in the PowerPoint, let me just backtrack. Also in the PowerPoint, it goes into a review of left-sided circulation, okay, so understanding when the left ventricles contract and it pushes the blood to the aorta valve opens up and lets that blood goes through the aorta to systemic circulation, okay, so which is this entire process here, okay. Now I'm going to get into later on when we're measuring a blood pressure with the brachial artery, how that concept also ties in, okay. So cardiac output, so I have the abbreviations here, okay, so CO stands for cardiac output. Cardiac output equals the stroke volume times the heart rate, okay. This information is extremely important to understand, especially this equation. There's another equation that you guys will pick up later on, which is called mean arterial pressure, MAP. And mean arterial pressure just means how we calculate the arterial pressure in the vessel, and it usually goes by the systolic and diastolic, okay, and heart rate. We're not going to get into that right now, but however, I want you to focus on this particular concept here that I wrote on the board. This concept is so super important for you to know because as nurses, when you do encounter patients that may have cardiac issues, cardiac output will drop, okay, so cardiac output will decline. And what that means is this, they're most likely not having proper circulation, okay, that's happening systemically. Now, what ties into this is cardiac output equals the stroke volume times the heart rate. So the stroke volume is basically the volume of blood that leaves the heart per contraction, okay, so these two actually kind of go together. So let's say, for example, the heart contracts, that force of blood now leaves the heart, okay, so that is the stroke volume. Keep in mind that stroke volume, just as a side note, can also be measured by something called ejection fraction, okay? And they can, there's a whole separate test for that. because the volume of blood that leaves the heart is important, okay? So we don't want just a little leaving the heart, okay? We want an adequate amount that should be leaving the heart to let us know that we have enough blood that's circulating systemically, okay? So this whole concept, and I'm explaining it this way just so we can understand the big picture. Now, as far as test questions, you're not going to have any type of math problems, okay? So you don't have to worry about that part. But just make sure you understand the relationship between cardiac output and how it equals the stroke volume times the heart rate, okay? And so how it all kind of ties together. Now, a few other abbreviations that we have, SVR and SV, okay? So when we're talking about blood pressure and understanding how we get to what is called the systolic reading and the diastolic reading, this all correlates to what's happening in the heart and then also in the vessels, okay? So it's the relationship of how pressure is flowing in those areas, okay? So this is why we have these two areas, systolic and diastolic. So anytime we have, and I'll put it kind of backwards, but I'll start here. Anytime we have systolic pressure or systolic readings, this correlates with stroke volume. Anytime we have a diastolic reading, this correlates with what we call systemic vascular resistance. Okay, I wish I had two boards here so I do have two boards. I just want to show you something really quick. Let me just write it. I'll come back in there. Okay, so hopefully this drawing makes sense. But I just want to give you a visual because sometimes, you know, people are like, okay, well, what's the systemic vascular resistance and stroke volume? What does that mean? Okay, so we have the heart here. Okay, so let's say this is the left-sided. Okay, this is the right-sided. Okay, right side of the heart. So let's just use the left side of the heart. Let's say this is our left ventricle. Okay. With the left ventricle, it has to contract, okay, to push whatever blood that's here to get to the aorta, okay? So once we have this contraction, and it's going to be a force of blood, it's going to be very forceful. And I think you guys remember this from anatomy. Remember, the left ventricle actually has very thick myocardium, okay? Very high amount of muscle, okay? So it can like have a large amount of force to push blood forward. So very forceful contraction is going to happen here. So when this forceful contraction happens, it's going to push this blood to the aorta. This is what we call the stroke volume, the volume of blood that's leaving the heart. Okay. Now, this stroke volume will go to the arteries, and this is what we call our systolic reading that happens at this portion. Okay, because that's going to be the highest pressure point. Okay, that's going to happen in the vessels. This is where the blood is first leaving the heart. It's like a very high velocity. If you can imagine someone opening up the gates, okay, and everything's coming through, okay, right at that moment. So this is going to be the highest velocity, which correlates to when you take a blood pressure, we notice that the systolic number is always the highest number, right? That's always the highest number. And the reason why it's a little higher than the diastolic is because this is the highest pressure point, the highest velocity of blood going into the vessels at that moment. Okay, are we good there? Now, when we talk about the systemic vascular resistance, now blood is flowing through this artery, okay, or arterial circulation. Now it's flowing through the arteries, and what's going to happen here when it's flowing through the arteries, I want you to imagine like water going through a water hose, okay? There's some pressure, but at some point, it's not going to be as forceful as when you first turn on the water hose, okay? But when it now starts to slow down as it goes through that vessel or through that hose, it's actually going to slow down the velocity a little bit. So as blood is moving through the arterial circulation, it's going to slow down a little bit. Something that we call systemic vascular resistance, which means the resistance of the vessel against the flow of blood. Okay, so it kind of pushes against the wall and slows things down. We still have velocity, but it's not as high as when it first started. Okay, so this correlates to the diastolic pressure. Okay, the diastolic. So therefore, when we do a diastolic blood pressure reading, it's usually a lower number than systolic. Okay, because by that time it's flowing through and the velocity is not as high. Okay, are we okay with that? Okay, so I just wanted to explain the concept because sometimes people are like, okay, well, what does all this mean? Another concept that was covered, I believe, in physiology is preloaded afterload. Not sure if you remember that concept, but just a really quick, easy way to memorize it. Preload is going to be the amount of blood that's in the heart before it leaves per contraction. Afterload is going to be the amount of blood that leaves the heart after contraction. The two are important, okay, because we do need a certain amount of preload and afterload in order to correlate with what we call this stroke volume situation. Okay. Okay, so hopefully we're good with those concepts. Now, moving on, we do have what we call measurements of blood pressure. So we have what is called the indirect measurement of blood pressure and direct measurement of blood pressure. The direct measurement of blood pressure you saw in the PowerPoint actually focuses on inserting a catheter into the radial artery, and we also do this. It's not the most common method of taking a blood pressure. It is the most direct, meaning that it's definitely more accurate, very invasive, so we don't do this all the time, but it is done in certain situations like surgeries and critical care units and things like that. Okay. However, the most common way we take a blood pressure is the indirect measurement, which is going to be using a sphygmometer or blood pressure cuff with our stethoscope. Okay. Now I'm not going to save time of going over how to take a blood pressure. How to take a blood pressure will be performed next week for our in-class activities for those people that are Tuesday, Wednesday classes. The Monday class, unfortunately, we're not going to be able to do that activity. But I will have a video posted online that you can see how to take a blood pressure. Okay, so we'll do that later and go into detail with that. Now, moving on, we do have two concepts that are really important which, for physiology, which is called short-term and long-term regulation of blood pressure. Now, this concept is very important, and I'm going to pull up the PowerPoint slide, actually. I'll just go from here, because it'll be easier. Okay, so when we talk about regulation of blood pressure, just to kind of backtrack, there's a number of things that can regulate blood pressure, okay? We know that our nervous and endocrine system kind of, regulates everything in the body pretty much. There's also hormones, okay, that regulate certain things. So we do want to look at the big picture of how blood pressure is regulated. If I can say what systems are extremely important, I would say top of the list, renal system. So, and I think we understand this concept from physiology. Kidneys, or the renal system, has a direct relationship with blood pressure regulation and flow. Very important to know that. About 1/3 of blood gets filtered through the kidneys per circulation, so it's extremely, extremely important. that kidneys are up to par with that. Our nervous system also is part of this process too, with blood pressure regulation, with the sympathetic nervous system and parasympathetic, and how that reacts on the cardiac system, okay? So just kind of having that in the back of your head, okay? Now, before I get into this concept, I want you to understand overall blood pressure. When the body has really, really good mechanisms to bring blood pressure up when blood pressure is low, okay, which is why the short-term and long-term regulation is usually on point, okay, when our blood pressure is low. However, when blood pressure is high, these mechanisms don't quite do the job, okay, or to the extent where it can bring it down to normal, which is why hypertension is always going to be an issue to the end of time. It's not going anywhere, and it's just because of how the physiological makeup is, okay? And then let's add in the risk factors, okay, for hypertension. So a lot of risk factors for hypertension are, lifestyle choices like diet and exercise, and unfortunately we also have the non-modifiable ones like family history and things like that. So combine all of that with just the physiological mechanisms. Hypertension is always going to be an issue. Okay, it's not one of those conditions that's going to be eradicated. It's just not. So saying that, it is important to understand short-term and long-term regulation of blood pressure. So short-term regulation of blood pressure, how can I define short? We can say that this is fast-acting, okay? We can say it's immediate, okay, type of control. So let's say, for example, you are just finished eating a big meal or a big breakfast. I love breakfast. I had a big breakfast this morning. I had pancakes and eggs and bacon. So anyway, let's say you had a big breakfast and now you're kind of tired, okay? So what happens here is when your body recognizes that your blood pressure is low, it'll put these mechanisms in place to bring it back to normal. And the reason why it needs to bring it back to normal is because we must make sure that there's proper blood flow, okay? Proper blood flow and blood pressure regulation, because we need blood to get to all organs and tissues so we can survive, okay? So we have to make sure blood flow is normal. So this is why I will bring it up as soon as it recognizes it's a little too low. And when I say bring it up to a normal level. So we go through the process here, and I'm not going to read this verbatim, but just to quickly go through, the nervous system is going to go through a certain processes to secrete certain things, to finally get to receptors that will act on the heart and the vessels, okay, to now kind of trigger things to move, okay. Now in the video I did explain, and I'll go into this again. But anyway, you can write this down, because trying to write on this is kind of challenging. So it'll activate what we call alpha receptors in smooth muscles of the arterioles to constrict. Okay, so it's going to cause it to constrict. It'll activate beta receptors in the heart, and it'll make the heart contract. Okay, so you just want to put here contract, and then here constrict. Now, if you combine that, a constricted vessel meaning that the vessel's tight. If the heart is contracted, that means there's a force of blood coming out. So you have a force of blood coming out into a tight vessel. The combination of the two is going to increase pressure. Okay. When we increase this pressure, this is what we want in situations where blood pressure is too low, and it'll regulate it, okay, as such. Okay. So that's what it'll do. Okay. So that's the normal process. Now, we want to add into this, there's hypertensive medications that can counteract these pathways. So we have the first two are alpha blockers and beta blockers that are for this pathway. Okay. So you see here how we have alpha receptor and then beta receptors. So we have what are called alpha blockers and beta blockers. Okay. So I'll give you the definition of what they're going to do. An alpha blocker is going to block the alpha receptor. Okay, so just what it says in the title. An alpha blocker will block the alpha receptor. And once it blocks the alpha receptor, it will cause the arterioles to actually dilate. Okay, so instead of its normal constriction, it will dilate. Okay, when it dilates, your blood can flow very nicely. Okay, no more pressure. Beta blockers are going to do just what it says. It will block the beta receptor. So when you block the beta receptor, this is going to cause the heart to relax. So if the heart is relaxing, it's not going to push out so much force of blood. Okay, and so therefore it will decrease pressure. Now, I must take a little time going over a concept of arterioles. Okay, so as a reminder, arteries take blood away from the heart, A away. Veins, we know, bring blood back to the heart. Okay, so this should sound familiar. So, we know that arteries, as far as microcirculation, this should look familiar. So microcirculation you went over in anatomy, yes. So with microcirculation, this is so important also when we are talking about blood pressure. Okay, because blood pressure is not only just up in the artery only and that's it. Okay, we know blood is flowing through other vessels. Okay, so we must discuss this. So arteries go down or break into smaller vessels, which are arterioles. Arterioles break down into capillaries. Okay. Capillaries will now flow into what we call venules, and then veins, larger vessels that bring blood back to the heart. So we know the normal function of a capillary is for exchange, okay, whether it's gas exchange or ions or waste or whatever needs to be exchanged, okay, it's going to be exchanged at the capillary level. When blood leaves an artery or is in an artery, it's at a very high velocity, very high force of blood going in. Okay, so that high velocity has to be slowed down at some point. Okay, that's very important to know. So when we have this blood that's going through an artery, the arterioles actually will act as almost like a cushion, so to speak, where they can constrict and dilate, constrict and dilate. They do call these variable to where it can now slow down this velocity of blood. Very important to understand this concept because arterioles are very important when we talk about blood pressure regulation. They're the major vessel here. Yes, arteries are important as well with it, but when we talk about like controlling the flow, arterioles are the ones that actually start to control the flow. Which is why, this is just a side note, which is why we know when patients have atherosclerosis, is plaquing in the artery, there's also a term called arterial sclerosis, which is plaquing in the arteriole. Which one do you think is worse? Arterial sclerosis, okay, because if there's plaquing here, that's a bad situation because this is the vessel that's supposed to help kind of manage things. So now if a person has lipid plaquing here, it's going to just really throw off not only pressure, but it'll throw everything off as far as circulation. Okay, both are bad, but you know, definitely this one can be challenging. Okay, so, and another concept I want you to understand, we need this to slow down because when we get to the capillaries, we want blood to be at a nice flow so things can exchange, you know, the way it should. We don't want a very high, imagine if this didn't slow it down. It would just be a high velocity of blood just going right through circulation. And that's not a good thing because it's probably going to, you know, break the capillaries. We're not going to have the right things flowing and exchanging as it should, okay? So we need arterioles to do their job. So this is why when you go here, why they're focusing on arterioles. Okay, there's a reason why. Okay. So I just wanted to explain that. So this is the long-term regulation of blood pressure. Okay. Now, you guys remember this from anatomy, physiology. Okay, the RAS system. This should look familiar to everyone. So we know the deal. Angiotensinogen and converts and all of that, getting down to vasoconstriction, aldosterone being released, causing sodium water to retain, and the whole deal. Okay, so we know that. Now, just to kind of quickly go into this, your hypertensive medications, there are a set that do counteract this particular pathway. Okay, so in the video you saw me go over things like an ACE inhibitor. So an ACE inhibitor is basically going to block this conversion here of angiotensin 1 to 2. And so that's the function of an ACE inhibitor. We also have a group of medications called Basal Dilators. Okay, and vasodilators will do the opposite of what's happening here. Okay, so instead of constricting, they'll dilate the vessel. We also have a group of medications that are called aldosterone receptor blockers, which will block aldosterone release. Okay, and so they'll stop that, which will hopefully not move forward in that area. Then we also have diuretics, okay, which will release the water retention that these patients have. And I think we all understand, again, the physiological mechanism. The more water you retain, the more body volume you have overall, which means that also increases blood volume. Okay, so with this situation, the more water a patient has, the more blood volume. This will also increase pressure. Okay, so, and I think I touched on this concept during class this week with you guys about water and blood going hand in hand. Okay, so that's a major important thing to understand. So anyway, when a patient takes a diuretic, they're going to urinate a lot, release that water, and when they release that water, it's going to decrease the fluid, but it's also going to decrease the blood volume as well. Okay, so therefore, the combination of the two should decrease pressure. Okay. Now, I said this in the video, and I'm going to say this again because this will help you clinically. When patients are given hypertensive medications, sometimes the medications work, okay, so, and it's fine, but then there's times where they may have to balance things, change the dosage, maybe change the medication altogether. And the major thing I want you to understand here, because we're going to go into hypertension, primary hypertension is the most common type of hypertension, okay, so we do have primary and secondary. Primary usually comes where people develop it, you know, from whatever lifestyle or, you know, modifications, things like that. The issue here is that because it is idiopathic, meaning that we have no idea what is the actual cause. We have tons of risk factors, but we don't have a cause. They have no idea what part of the pathway here is the issue. Okay, but the medications are giving to patients based off of clinical trials. Okay. And I'm quite sure you guys are learning that in capstone. With clinical trials, patients are given medications. They have one group, another group, okay, to figure out, okay, which medication's working for this condition. And then based off of their findings and research, then they'll say, okay, this medication works. And then, you know, the pharmaceutical companies say, okay, we'll give them this one. So that's how that works, okay. But the reason why I'm saying this is because in the future, and you guys may have heard of this at some point, people that do have hypertension may have their medications change, and you know, you're probably wondering why we're changing the medication. Well, it's because we don't know really what the problem is. Okay, so we're just kind of trial and error here, figuring it out, and then figuring out which one will actually work. But we know it's going to be something here. Okay, does that make sense? Okay, so I just wanted to add that piece in because it'll help you later on. And that's that. Okay, I want to hurry up because I don't want to spend too much time just on this chapter. Okay. As far as primary hypertension or hypertension in general, with hypertension, please make sure you go over, oh, I'm sorry, let me go back. I keep forgetting this isn't touchscreen. Make sure you memorize these numbers. Remember, these are the only numbers I'm going to have you memorize for the entire term, okay, which are the blood pressure classification numbers. So, yeah, that's that, okay. Primary hypertension is when it is idiopathic, meaning that we don't have a known cause for it. You should know everything about this, okay? So there's nothing I can pinpoint and say, oh, just focus on this. You should know everything about hypertension. The risk factors that are here, the end organ damage, and I'm going to go into a little more detail with this one. So this is the issue. With hypertension, patients can have end organ damage, okay? Which is why when patients have hypertension, we want this controlled, okay? Because we don't want it to lead into something else, okay? And I had a perfect example of this situation this upcoming week. You guys know I'm a chiropractor, and I have a patient. Sometimes patients come to me with headaches and all types of pain. Anyway, long story short, this patient was constantly having headaches, a lot of pressure in the eyes. They thought she had an aneurysm, so they checked for that. Okay, they did an angiogram and all these tests, and thank God she didn't have an aneurysm. And all this time she's explaining to me, and I said, "Is your blood pressure high?" And she said, "Well, yeah, a little bit here and there. We're not sure." They gave me blood pressure medication, but I don't want to take it. Take your blood pressure medication, okay? So it'll stop all of these symptoms that you're having, okay? Because everything that she was explaining to me were things that actually can lead up to everything that's listed here, okay? So when a patient has hypertension, the problem is this. It can affect these following organs, so please make sure you know these organs. It can affect the heart, the arteries, the kidneys, the brain, and the eyes, okay? And so if they have hypertension that's not controlled and they're not taking their meds, okay, what's going to happen is it's going to put more work on the heart, and it can unfortunately lead them into possibly a heart failure, okay? Or, if it doesn't get to a heart failure, they'll just have like angina and things like that, okay? It can lead the pressure in the arteries to be too much and can lead them to a possible aneurysm, okay, like the case I was explaining. Or it can lead them into kidney issues, okay, where they can lead to kidney failure, because we know kidneys and blood pressure regulation go hand in hand. Or it can lead them to having brain issues to where they can possibly have a stroke or have retinal issues with the eyes, okay? So very important to know this, because clinically, these are the areas that you guys will be assessing with your patients, okay? When the blood pressure is high, and trying to figure out, okay, well, what's happening here? So just make sure you have an understanding of, and I know this looks kind of crazy, this flow chart, but if you go through it, it makes sense. But just have an overall understanding as to what's happening with each organ, okay? So if we have a test question with it, you should be able to know, number one, that these are the organs that are involved, okay? And then just kind of have an overall understanding as to what kind of damage could happen to the organs. And then you should be fine with that. I go over the modifications. You can go into that. Secondary hypertension, really super easy. Just a patient has a primary condition, and then a hypertension happens after that. Okay. And then hypertensive emergencies and urgencies are pretty straightforward. One has more damage than the other. And then hypotension, really quick, we only have 2 slides here. With hypotension, patients can have low blood pressure. Most of the times this can be due to medication history. So let's say a person is on hypertensive medications and is not quite controlled, or other, some other medications. It could also come from like fluid loss or blood loss if they have a lot of that. It can also happen if they have like arterial stiffness. Sometimes patients do have conditions with their vessels, okay? So just a number of things. But when patients have low blood pressure, I want you to know that this is usually developed, or how can I say, defined during postural changes. So like, let's say if someone's, you know, in the bed and then they're getting up, okay, or they're on the floor and then they're jumping up or something like that. So it's usually during postural changes that the blood pressure is going to drop, okay? And this is also something that can commonly happen as we get older. So some of your geriatric patients may just have this just because of the aging process, okay? So, and that's that. Okay, I'm sorry I'm rushing. I just want to make sure I get through. I can't. Oops, sorry. Okay, so 18. I'm going to write something on the board here that will make your life much easier in understanding this. Now, chapter 18 has a lot of terminology here, but I'm going to write a flow chart here that will help you overall with this whole thing. Okay. Terminology right. Because there's a lot of abbreviations in here. Coronary heart, coronary artery disease, ACS. Okay, so let me start here, and I'm going to add in some things as I go along. The chapter 18, the first portion that covers like coronary heart disease, and I think it's like the first 12 slides or so, and it just has a lot of information, just all over, a lot of terms, okay, ischemia, and you know, the atherosclerosis, and the plaquing, and the CKD, and the, not CKD, CAD, and all these things. So the best way to look at it, I know it's separated into different slides, but they're really all kind of talking about one common thing here. Okay, so I just want to put it in this flowchart format so you can see that it's really just talking about one major concept here, which is when patients will end up with what we call coronary heart disease. Okay, so to get started, we do start off by explaining what is considered atherosclerosis. It talks about atherosclerotic plaquing, which occurs when patients do have certain risk factors. Okay, so let me put the risk factors here, which are important to know. So I'm going to put over here risk factors will include diet, increase in saturated fats. Okay, diets high in saturated fats. Okay, so all those lovely things that taste good but that are not good for us. Okay, so we know what they are. So this portion is very important because that is the major risk factor that leads to this type of situation. Okay. Now, when we're trying to diagnose if a patient does have atherosclerosis, or another term that you'll hear is hyperlipidemia, or making sure that to diagnose if they have too many fats in the bloodstream, the best blood work that's used for this is a lipid panel. Okay, so let me just add this here. So in the video, you'll see me go over lipid panel, okay, and I go into detail with how it's broken down by cholesterol, triglycerides, HDLs, and LDLs, okay, and what they all mean. Now, just to confirm, for test purposes, when I explain the lipid panel, what I'm expecting you to know is basically what each thing is used for, and I explain what they're doing, I should say. You are not responsible for numbers. I'm not going to test you on the ranges. We don't need to know that at this point, but just understanding how that correlates to when we're talking about CAD. Okay, so with emphasis on HDLs and LDLs, because those are the ones they really kind of zone in on. Once a person has their cholesterol levels, yes, we know it's elevated. However, when it's elevated, we really need to focus on what those HDLs look like. Okay, what do those LDLs look like? Because HDLs are the good cholesterol, so to speak, and if they're low, that's not a good thing. The LDLs are bad. If the LDLs are high, that's not a good thing. So they look at those numbers, and they are a little different between men and women, okay, the ranges. So, but anyway, that correlates with this. Now, once we have all of this going on, okay, and let's say the patient is diagnosed with atherosclerosis, okay, so they do have some sort of lipid issue occurring. Now, what we are concerned about is if that plaque happens in a coronary artery. If it happens in a coronary artery, that is not a good situation at all, because I think we all know that coronary arteries supply blood to the heart muscle tissue, okay? And so if there's a blockage, that's going to block blood flow to the heart. The heart's not going to function. So the terminology for this is what we call coronary artery disease, or you may see it abbreviated as CAD. So when you see CAD, you know what that means. Sometimes I feel like we need a whole class on abbreviations, because we have so many, and so many abbreviations. Okay, so CAD, coronary artery disease. Now, in the video and also in the PowerPoint, you'll also see me further break down what we call like an acute coronary syndrome versus a chronic. And when we start explaining coronary syndromes, this is a situation where now this patient is symptomatic. Okay, so they have the diagnosis here. Okay, they have plaquing. Let's say they do some sort of angiogram or echo or whatever kind of testing, and they see, oh yeah, they have a plaque there in the coronary artery. But now let's say that this patient is symptomatic and they're having a lot of chest pain, or another term we use is angina. So now they're having angina, all different types of angina. So now they're symptomatic, and we're trying to figure out which category they're in. In the video and in the PowerPoint and in your textbook, they really go into a lot of detail explaining the different types of angina and how it correlates to which one is worse than the other and that whole thing. Clinically, and for those of you who are in the field know this already, when a patient has angina, we don't really get into that. We just really need to know why. Okay, so we don't get into which one's worse, is it acute or chronic, and that whole thing. But the reason why we break it down here is just so we can understand the physiology of it, okay? So, saying that, let's say this patient has chest pain, and I'm going to start with the chronic first, okay? So let's say they have an atherosclerotic plaque in the coronary artery. It's there, sitting there, hasn't changed much, just been there for quite some time. It's there, but it's still causing them enough symptoms to have this looked at. So let's say they're having chest pain. The chest pain comes and goes, and let's say, during rest, it'll calm down if they don't exert themselves too much. Or if they're given certain medication, like a nitroglycerin or something like that, that'll calm it down. Okay, so they're kind of in this situation where maybe it's a little more manageable. Okay, they still have a coronary syndrome, but it probably could be a little more manageable here. Over here, when we say acute, now we're talking about this patient having an atherosclerotic plaque in the coronary artery that's maybe getting bigger, maybe it's changed and it's like dislodged or moved somewhere or did something. And now this situation is getting worse, in a sense where the symptoms are not only getting worse, but inside the vessel is getting worse. Okay, so now we consider this an acute coronary syndrome. They're having chest pain, a lot of chest pain. At this point, we're not saying they're having an MI until we do further testing. I'm going to get into that in a second. But we still call this an acute coronary syndrome. Okay. Now, for testing, for further testing, we want to look at an ECG and also cardiac markers. Okay. So, an ECG is just going to tell us the electroconductivity of what's happening in the heart at that moment. Okay. Now, it's not telling us, it's not the major determinant factor that a patient's having a heart attack. It just tells us what type of heart attack they're having or how complicated it is. The major determinant factor that a patient's having a heart attack is a blood work that's called looking at the cardiac markers. And in particular, we look at troponin. Those of you who are here for the 3 o'clock, if you don't mind, just give me 5 more minutes. I don't try to write this up. So cardiac markers, we're looking for troponin. Once a patient has blood work performed and troponin levels are elevated in the blood work, they are considered to be having a myocardial infarction. Okay, and the reason why troponin is actually part of the sarcomere and part of muscle fiber. So when we talk about breakdown of sarcomere, and when we're talking about the heart muscle tissue dying, the tissue's dead and it breaks apart. So those things are going to flow in the bloodstream. Okay, and when that troponin levels show up and elevate, that lets us know that that's correlated with it. Now, certain panels, just so you don't get confused, certain panels do have other things like creatine kinase, but just to make you aware, and this is what I'm hearing also for people that are working in the field, clinically they only look at troponin because creatine kinase can also correlate with other types of conditions. Okay, so we don't want to get that confused with the heart attack. So, troponin. ECG is going to tell us if the ST segment is elevated or not, which is why we have this as ST-EMI and N, non-ST-EMI. The ST segment is the last portion on the ECG, okay, which means that that's when the ventricles should be relaxing at that point and getting ready to fill for the next cycle. The problem here is that, especially for this one, the ventricles are not relaxing, they're actually firing, okay, and they're contracted too much, which is now going to throw off the reading on an ECG, and it's going to be, the segment is going to be elevated. That lets us know but the ventricles are still contracting. The ventricles are still contracting because it's trying to compensate for the damage that's happened to the heart. Does that make sense? So this is why when we see this on the ECG, this lets us know the amount of damage that has occurred, okay? And not to say that it's because of the heart attack, but it's the amount of damage that happened because of the heart attack. But it's not the only distinguishing factor. A non-ST elevation, the ST segment is normal, okay? That's fine. But because this has MI attached to it, That lets us know that most likely this is a MI that was diagnosed by troponin levels, okay? So as long as those troponin levels are there, that patient is having an MI, no matter what the ECG readings show, okay? Whether it's elevated, ST segment or not. Once you have this in the bloodstream elevated, it's definitely an MI. And then in some cases, you can have a patient that has a chest pain and, you know, there's nothing going on, there's no MI, okay? But it's just that the atherosclerotic plaque is really large enough to, you know, give really severe symptoms, okay? And so that, they'll still have to, you know, manage that as well. So does that make sense for the first part? Okay, so like I said, all of those slides just can be, you know, combined together, okay? And like I said, I know it looks like all this information here, but it's really just discussing one common theme, which is coronary heart disease. Now, the rest of the PowerPoint focuses on valvular disorders. In the video, please pay close attention to that video, because even the updated one I'm trying to do, I do this whole visual thing here, and I'm trying to figure out how to continue that for the updated one. But just make sure you pay close attention to the visual, because I do put a drawing there of the heart, go over the different valvular disorders, and what you should be focusing on is the name of the valvular disorder and what type of effect is happening to the chambers. Okay, so that's what we're going to focus on. What type of effect is happening to the chambers. And we go over 3 infections of the heart. They're very simple. There's 2 bacterial, 1 viral. So it's just a matter of knowing the names of those infections and the damage that is happening to the heart. If it's a bacterial infection, antibiotics will be the treatment of choice. The viral infection, I don't go into a lot of detail with it, but it can change the musculature of the heart. So that's the main thing I do focus on with that one. And I want to say that's about it for 18. 19 focuses on heart failure. What I will tell you, and I said this in class and I'll say it again, if you are not comfortable with the flow of blood in and out of the heart, please make sure you focus on this first. I cannot stress enough the anatomy. Anatomy and phys are foundational courses for this course. It's going to come up again. It's just inevitable. It's part of it. So this, you should just have this in memory. Okay, if you don't have it in memory, focus on memorizing this first, because it'll make more sense when we now get to the heart failure topics and understanding what's happening right and left. Okay, I do put a lot of emphasis on what we call the backward and forward effects. So a lot of your questions for heart failure are going to be focused on understanding, you know, if it's right-sided, left-sided, and if it is right-sided or left-sided, what are the symptoms the patients are going to have? Most of the questions are going to be focused on symptoms, signs and symptoms, and diagnostic testing. And so we do go over some diagnostic testing as well. But in order for us to understand those signs and symptoms, we really have to understand the normal flow of what's happening, so we can understand the blockage. And then for 20, there's a few concepts, and I have it all written down in the outline that I gave you. The number one thing is making sure we understand the overall pathogenesis of shock, just the whole underlying pathogenesis for any type of shock. Then there is a table in your textbook, box 20-1. It goes over the different categories of shock. That I do need you to know. I usually test you on that, because You should know the categories and then the examples that fall under those categories. And it's in the PowerPoint. After that, it goes into the different types of shock and the different, information behind it. I put a lot of focus on septic shock, anaphylactic shock, hypovolemic shock, because those tend to be more common. Cardiogenic as well, okay, can be common. So just make sure you know what type of, what the reaction is happening, or I should say, the mechanism of those shocks, those different types of shocks. And those questions are pretty straightforward, but if you follow that outline of what I have with the shock, then you should be fine. Okay. So, I'm sorry, I'm looking at this time here, it's 2:59, I do need to wrap it up. Do you guys have any particular questions from chapter 16, 18, 19, and 20? Again, if you are shaky on your anatomy and physiology, for cardiac anatomy and physiology, what you should review is the flow of blood, microcirculation. You should also review just the overall anatomy of the heart if you're not comfortable with that. And you can review the cardiac ECG physiology. Not in so much detail but you should know how it correlates to cardiac cycle, just so we can understand when a patient's having an MI and what that ST elevation means, okay? So if you're not comfortable with that, you may want to review cardiac cycle and how it correlates to an ECG. And then that's about it as far as, what we're covering here. But also, if you're not comfortable with blood flow and velocity of blood, I would cover that as well. If you're not comfortable with what's happening in the artery versus a vein, I would cover that as well. Okay, and that's just anatomy and physiology review if you need that. If you need anatomy and physiology review for cardiac, look at chapter 17. Chapter 17 in your textbook is your basic chapter for anatomy and physiology for cardiac. Okay, and you should be able to find everything there. If you need anything additional, let me know, but I do have some embedded slides with A&P, and then I'll be uploading some more information, okay? Okay, so I need to switch over to the 3 o'clock group. And keep in mind, for those of you who are here for cardiac, you are welcome to stay for this tutoring session for 3 o'clock because this information will also be another good review for you to get ready for the midterm. Remember, our midterm is coming up the following week. Okay, not this upcoming week, but the week after. So, and the midterm is cumulative for the first 4 weeks. Okay, so if you want to stay, you're welcome. If not, you can go home. But this is being recorded. All right, so okay, so to get started with you guys, last week's tutoring session also covered some of this information. So if you were able to watch that video, you'll notice that I did design a chart, okay, that was on the board here, that I think is a really good way to get prepared for this chapter. Chapter 10 is pretty clear-cut, straightforward information. It covers 4 different hypersensitivity types. When you are looking at information like this, the best way to study to help prepare for test questions, and this can be for any chapter, any concept, you want to be able to take at least 2 to 3 topics or even 4 topics and compare and contrast, okay? And so this chapter, I think, is a really easy chapter to do that. There were some charts that were already embedded in the PowerPoint at the end to kind of help with that information. So when you look at the different hypersensitivity types, we should be able to say, okay, well, this one has this immunoglobulin, or we know doesn't have an immunoglobulin, it's just T cells. We should know that this one has tissue destruction, this one has dermal reactions, you know, so those things that are going to stand out, those are the things that you want to look for, you know, when you're having test questions like this, okay, for those questions. Now, as I said, also the hypersensitivity types, you should know the examples. There's a lot of focus on type 1, I would say, out of all the types. They're probably the most common type, okay. Drug reactions, when your patients have drug reactions, are probably, excuse me, the most common example for this one. With type 1, we should know every single thing about it. Like, you should be able to explain what's happening, okay? Was having a conversation with one of the students last night, and they were forming a study group, and she said, well, we should start with, you know, teaching each other the information. And I encourage that. If you guys are working in a study group, or even if you're not, you want to teach your children or talk to your dog or whatever, you know, be able to recite it, because if you can teach it, you know it, okay? And so sometimes we're so comfortable with just like reading information and just, you know, answering during practice questions, which are good, but you also want to add in that verbal piece because it allows you to comprehend and think the information through. So, with type 1, I'm just going to throw out hallmarks for the sake of time, because we do have a lot of chapters here that I have to get through in an hour. So hallmarks for type 1, we have IgE, mast cells is definitely a hallmark. Hypotension is a hallmark. So really the entire mechanism here is a hallmark. So understanding that when these patients do have allergic reactions, they you know, go through this whole process where the mast cells degranulate, they release histamines, and, you know, there's vasodilation that occurs and hypotension and all these things that are happening. It is an understanding, too, to make sure that when patients undergo a type 1, we do consider this an anaphylaxis. Anaphylaxis is an allergic reaction. If the anaphylaxis goes on too long, then these patients can lead to what we call an anaphylactic shock, because the hypotension is going on too long. Now, that's a totally different topic, okay? And you'll see this upcoming week we're going to go into shock, okay? So just to make you aware of that, they are two different things, because sometimes when people say, oh, they're going to anaphylactic shock, meaning the same thing, it's not the same thing. The patient has to have anaphylaxis first, okay, and then the shock. And just to also make you aware as a side note, because most of you are getting ready for your quiz at 5, you know, for the 5:30 class. I do another extensive review, and I'll tell you, this week the review has been long. So it took me like, oh my gosh, over an hour. I think last night it took me 2 hours because I had so many questions that were being thrown at me. So, you know, we're going to review this in a lot of detail, okay, to get you ready for your quiz, so don't worry. Okay, so anyway, so those are the hallmarks. You should also know, like, the examples as well. Type 2, the hallmarks we have here, as far as immunoglobulins, it could be IgG or IgM for test purposes. I don't confuse you with that, okay? So just to make you aware, it's one or the other, depending on the situation. However, we should also know with these types, the name that goes along with it, so cytotoxic, cytolytic. We should also know, this one's pretty straightforward, it's just a matter of these cells just being immediately destroyed, and then knowing the examples with that. Type 3, also known as Arthur's reaction, this one has two kind of subcategories where we can have like our autoimmune diseases, and then we also have conditions that come from persistent infections. So with the autoimmune diseases, we have those examples like lupus and others. And then the ones that are persistent infections, we have like glomerulonephritis and then the farmer's lung arthritis, things like that. And the overall theme for this, which is also a hallmark, is that this causes tissue destruction. Okay, tissue destruction is the hallmark here because that's what's happening in the mechanism. Type 4, a lot of hallmarks here. Number 1, T-cell mediated. It doesn't have any involvement with an immunoglobulin. Second hallmark is we are looking for dermal reactions. The mechanism happens that will lead to a dermal reaction. A longer time frame, which is why it's called delayed hypersensitivity, and then we have our examples with that. Okay, so as I said before, it should be very kind of straightforward. Does anyone have any particular questions with chapter 10? Okay, chapter 11 has a lot of information here, and I explained to you to please make sure you study the first 12 slides. Okay, and then starting slides 13 through 50 are each condition, and also it's in the spreadsheet, okay, which is, people find that a little easier to memorize, okay. So to backtrack with chapter 11, the beginning of this covers some basic knowledge that we should know overall about white blood cells and what's happening with these types of leukemias, lymphomas, plasma cell myeloma, and so forth. So a couple of concepts that we should know by now is this: the terminology of what a leukemia, a lymphoma, and a plasma cell myeloma is. So we should be able to define that. A leukemia is a cancer in a white blood cell circulating in blood. A lymphoma is a cancer in a white blood cell circulating in lymphatic tissue. Understand that the name goes with the location. Anytime you see anemia, we're going to discuss something that's in the blood, okay? Anytime you see lymphatic tissue, oma, we already know that's the exception to the rule, okay? So these are considered malignancies. Plasma cell myeloma has its own terminology, and it's because it's in a class by itself because of the way it behaves. But we should know that this is attacking B plasma cells, okay? B plasma cells, or you can also say antibody secreting B cells. We should also know, as far as the lineage, and this goes back to anatomy, that anything that's in the lymphoid lineage is a B cell, T cell, or natural killer cell. Everything else falls under the myeloid lineage. Okay. Once we have that information, we should also know a little more information about lymphoid cells, which are lymphoid cells can flow through both blood and lymphatic tissue. Yes? And when they flow through both blood and lymphatic tissue, the location just means what type of cancer the patient has. So if you have a patient that has a cancer of a B cell that's flowing through the bloodstream, then that patient has a leukemia. If that patient has a cancer of a B cell that's flowing through the lymphatic tissue, then that patient has a lymphoma. There are some lymphoid cancers where patients can have both, okay, like ALL, as it gets aggressive, okay. So just keep in mind the lymphoid cells can flow through both areas. But now when you have a myeloid type of cancer, like a cancer of a neutrophil or eosinophil or anything like that, that is only going to take place in the bloodstream, which means that those cancers will only give rise to a leukemia only. Are we comfortable with that? Yes, okay. Now, as far as acute and chronic is concerned, these are also two concepts we should understand. So anytime you have an acute version of this cancer, this means it's attacking immature cells, and we also call this, what's the other name for it? There's another name for acute leukemias that we call blast stage. Very good. We also call this the blast stage. Okay, very important to know that. Because sometimes, I want to say clinically, they may use that terminology a little more than, or acute and blast, whichever one. When we talk about chronic leukemias, this attacks the mature version of the cell. Okay, so the mature version. So we know that information. Now, everything else in 11 focuses on signs and symptoms that are common across the board with different types of leukemias and lymphomas. I'm not going to get into detail with that at this moment. I'm quite sure you guys know what they are. Keep in mind for test purposes, those things are important to know overall, but they're not going to be the determining factor to help you on a test question. Okay? The determining factor to help you on a test question is making sure you know the hallmarks, what stands out with those particular diseases, okay? Everybody's gonna have fatigue and all of that, okay? But we wanna make sure we know what is it that is, the focus. The other thing that we look for are or I should say that's in chapter 11. Can't get tired. Still got the rest of the minute to go. We're also looking at diagnostic testing, okay, how we diagnose these cancers. So these cancers are diagnosed through blood work, obviously. Okay, so the best way to determine a blood cancer is look at the blood. So just make sure you understand what type of blood panels are done. So we are looking at, yes, CBC, and what we're looking for there. We should also know that they do a peripheral smear because that is definitely the determining factor that this patient has this type of cancer by looking at the cells. They must look at the morphology of the cells. Blood work along with bone marrow transplant and biopsies are definitely the definitive sources. Okay. What else? Cancer treatments. Now, I usually don't put a lot of treatment questions on my exams, as I told you guys. If I do, it's going to be something very clear cut. If the patient is missing this, you give them that type of thing. However, when it comes to cancer treatments, I don't should say waste time, but I really don't put questions with that because there's not much variety when we're talking about treatment for these types of cancers. If a patient has a leukemia, the best treatment of choice is going to be chemotherapy. So there's really nothing, variety that we have, okay, with these types of blood cancers. Some do also include bone marrow transplant, okay, depending on the cancer type, but chemotherapy for sure, okay, to just kind of globally attack this. Now, when it goes into the different cancer types, we want to look at, and I'll try to go down the list that's on the spreadsheet. CML, we know the hallmark is going to be what? I'm going to do a Q&A for you guys because you're about to take your test. So you should be somewhat ready. Somewhat ready, right? Somewhat. So what's the hallmark for CML? What stands out here? Which one?
Enlarged spleen.
The enlarged spleen is for hairy cell. But CML, chronic myeloid leukemia, what's the hallmark for this one?
It's a man and not a woman, or more, or that, we're talking about, or more?
No, what's the hallmark? What stands out? What is, if you have a test question that has this, let's say you have for CML, we have a test question. What is a feature of CML? Fatigue, the patient has splenomegaly, the patient has lymph node enlargement, or the patient has what we call a Philadelphia chromosome.
Oh, the Philadelphia.
Philadelphia chromosome. We should know that. That's a major hallmark for this. This is the only feature here that kind of stands out from the rest. No one else has a Philadelphia chromosome on this list. So we should know that. And it's in red here. The presence of the Philadelphia chromosome. Remember, the way to read this chart that I put here, anything in red is a hallmark. You also want to take a look at items in black as well, okay? The items in green are just kind of shared across the board, nothing really too special, okay? So some people are going to have, pain, infections, and all that here and there, that type of stuff, okay? But we want to look at the things that really, really stand out. So the next one we have on the list is AML. What stands out here is that there's malignant immature white blood cells that are over 20% blasts. Excuse me. Oh yes, they're over 20% blasts, meaning immature cancerous cells. They do also classify this as, when we talk about AML, these patients are definitely very high susceptibility to infections. And this is across the board, not only for AML, but also for any acute leukemia, okay, even ALL. That information you should know and understand, not only just for test purposes, but clinically. If you have a patient with acute leukemia, just be mindful that they are definitely more prone to infections, anemias, bleeding issues. They're gonna have more bone marrow suppression because that type of cancer, acute cancers, I can't get it out. Acute leukemias are aggressive. They are very aggressive. So they're going to be, having that situation. So that's all listed here. CLL, I have the hallmark here, it's defective apoptosis, because that's the only thing that kind of stands out. But I do want to make you aware that most blood cancers do have a defective apoptosis, okay, which is the reason why, it's still going on. However, with CLL, another hallmark that I would say is that, remember I was explaining to you that these are individuals that don't know they have this cancer and they just kind of find out just by routine blood work. So the takeaway from this one is that when patients have CLL, the signs and symptoms are not as abrupt. Okay, so the signs and symptoms are very mild, almost silent. They're not sure what's happening in the beginning until they actually have diagnostic testing done to diagnose this. Okay, so once the blood work is done, then we can see what's happening. It's getting cold in here. Okay, what else? ALL. We should all know this. What's the hallmark for ALL? Children. What else could we kind of say stands out here?
The bruising.
Okay, very good. So the signs and symptoms that happen in children with childhood cancers do stand out a little more than with the adults. Okay, so they're going to have easy bruising, possibly appetite issues, okay, maybe not wanting to have mobility or walking, okay. And really because of bone pain, I mean, we don't know if the 1-year-old or 2-year-old's having bone pain, but, just from not wanting to move around as much, okay, will let us know that part. And also appetite issues, okay. Now appetite issues can happen in a lot of different cancers as well, but it can be stand out more with children, okay. All right, hairy cell. So what are some features here for hairy cell leukemia? Splenomegaly, yes. One of the major hallmarks here is that, what they say, 80% or 90%? 90%. 90% of cases with hairy cell leukemia these patients will have splenomegaly. Okay, so that is definitely a hallmark. Okay, obviously the hairy cell projections. We can also say that with hairy cell leukemia, the complete remission rate is pretty good. Okay, with chemotherapy. So that sort of stands out from the rest. Okay, and I think that's that. Now, plasma cell myeloma, also known as multiple myeloma. I always say this, but no one should get this test question wrong, because almost the entire thing stands out here, okay? Because this really behaves totally different than the other cancers, okay? So what are some key features that we know for this particular cancer? Anything that stands out to us with multiple myeloma? Okay, Bench-Jones proteins, okay, so that's a major factor here. These patients do secrete these proteins because, remember, it's a cancer of these plasma B cells, okay, which means that they're now going to secrete a particular type of antibody, okay, and these proteins are part of this, so they will have Bench-Jones proteins. Bench-Jones proteins are definitely a hallmark feature. These proteins can be detected in the blood and also in the urine. So if blood work is done, you'll see elevated proteins. If the urine analysis is performed, they're going to have elevated proteins. Okay, so that is definitely a hallmark feature. What else is a hallmark feature? Which one?
Anemia?
Not anemia so much. I mean, they could. That's not as hallmark as some other things. Any cancer technically could have anemia because of bone marrow suppression. So that's kind of a shared sign or symptom, or a shared condition.
The calcium levels?
Thank you. Calcium levels. So don't forget, these patients are going to have increased calcium in the blood. Why? Because they also have bone destruction. They're going to have also not only just bone destruction, but they do also have other organs that are affected with this condition. And this is the first time that we're seeing this with any of the cancers that we discussed. So if you remember from the PowerPoint in the video, we discussed that they can have kidney involvement, lymph node involvement, they can have liver involvement, okay, and the bone. And it's important to know those areas because those are the areas that they're going to have issues, okay. Do you guys know, or can you explain to me, why are they having, these patients can have renal damage? Why can the kidneys get damaged in this type of cancer?
Are you talking about filtration?
Yes. What is being filtered that's causing the damage? The proteins. Okay. Understand, these patients have an increase of Bench-Jones proteins. These are a particular type of proteins. It doesn't matter what type they are. But we don't want too many proteins trying to cross over the nephron. Okay? That's not going to be a good situation. So the more proteins they have trying to get filtered, this will actually start to cause kidney damage. About 50% of cases of this can lead to renal insufficiency. That is very important to know. Because with this cancer, their body actually starts to, I don't want to say break down, but there's a lot of systems that are involved here with this cancer. Yes?
When there's too much protein going through the system, like the renal system, and the patient is urinating it out, is that what makes the urine cloudy? Potentially?
The cloudy urine can come from a couple of things. Sometimes it can be like from infections. It can be from a number of things. It'll change more so the specific gravity, and like the density of urine gets a little heavier when there's more things coming out the urine. But the cloudiness, from my understanding, is usually more so from like microbial things, like infections and stuff like that. But it could be a possibility that can, change the coloring a little bit. Okay, so, where was I? These patients have pathological fractures, which is why the calcium levels are elevated in the blood. So pathological fractures are when a person has a disease process occurring and all of a sudden the bone starts to break, okay? They don't need to do any kind of movement or anything special, okay? But it's just because the disease process is causing an extreme weakening of the bone. And you can detect this by doing an x-ray, okay? So just to give you a quick example of how this can be presented to you. So let's say, for example, you have a 60-year-old male, okay, come to you, they're having a lot of back pain. And let's say, okay, you're doing a workup, you check the urine, check the blood. In the blood work, it shows that they have high calcium levels, maybe some proteins are there as well. You check the urine has a very high amount of proteins, okay. Patient's not diabetic, that's clear, okay. But now we're recognizing that, okay, well, he has back pain, he has these things secreted in the blood work and the urine. So now the next thing, especially once the calcium levels are really high and there's no other purpose for that, the next thing to really take a look at is to do an x-ray. An x-ray, especially if this patient's having a lot of pain in that particular area, you want to take an x-ray of that area, because that could be telling us that, okay, well, maybe there's some sort of bone destruction occurring. The areas of bone destruction with multiple myeloma are the skull, the spine, the rib cage, and the pelvis. And it's listed here in the spreadsheet, okay? We should know those areas, okay? Very important. Is it listed here? No, it's not. I'm sorry. It's in the PowerPoint then. I'm sorry. It's in the PowerPoint. But those are the areas, and another term that is used for this is called honeycomb appearance on the x-ray. So the bone looks like it has, holes in it. Okay, little holes.
You said skull, spine, and where else?
Skull, the spine, the rib cage, and the pelvis. Those are usually the areas. And I'll tell you, the cases that I've heard with multiple myeloma is classic kind of textbook. Like, how sometimes people say certain conditions aren't like textbook, because the body can behave and do what it wants to do. But certain conditions do have, yes, it's going to be in those regions. And so usually with multiple myeloma, most likely they're going to have those regions that have that issue. The skull, the spine, anywhere in the vertebrae, the pelvis, and the rib cage, okay, can actually have bone fractures. So the point here is that multiple myeloma has a lot of involvement, okay, a lot of involvement, much more than the other ones, which is, again, the reason why no one should get this wrong as a test question, because it really has very distinct things, okay, that are happening. Now, when it comes to lymphoma, okay, so lymphomas, we have two different types, Hodgkin's and non-Hodgkin's, okay. We can easily compare and contrast these two here. So Hodgkin's, as you can see in red, the hallmark here is the Green-Sternberg cell. Okay, so when they do a biopsy, they're able to see these cells, and we know, okay, that's how we diagnose that. The non-Hodgkin's one does not have the Green-Sternberg cell. The Epstein-Barr virus is a risk factor for it, so the Epstein-Barr virus can be a risk factor for either one, okay? And just as a reminder, the Epstein-Barr virus is the virus that causes mono, okay? And not to scare anyone, because, sometimes people have contracted mono. Not to say that every case, okay, leads to this type of lymphoma, but it's just a risk factor. Okay, that's it. Now, the other things that are different here, we can say are the age ranges. Okay, so just in case if we have a question like that, with Hodgkin's lymphoma, it's usually a younger age group, 20 to 40s, whereas with non-Hodgkin's, it's usually older age group. And they do also say patients that are immune compromised that have conditions like HIV and AIDS are a little more prone to this as well. Everything else, pretty much they have saying some common things when it comes to how the disease process presents itself. So they're going to have lymph node enlargement. Understand when the lymph nodes get enlarged, they are painless. They're not painful as you would imagine. And they're not mobile. So remember, we know the characteristics of malignant tumors, okay, from chapter 7. So if they have a lymph node that's getting large, okay, it's palpable, you feel it, it's not moving, it's sort of fixated, that's along the lines of what we call the malignancy, okay? Different than when you just have lymph node enlargement just from like a cold or, type of head cold, things like that. So when lymph nodes become enlarged, they do say the way this presents is usually above the diaphragm first. So they say the cervical lymph nodes are usually the first involvement here, then possibly axillary and around this region. And then as the disease process progresses, it goes below the diaphragm, okay? So into the pelvic region. So again, everything else is pretty much the same here. The signs and symptoms also the same. As I said in the lecture video, I believe I said this, I am going to stay away from questions about sweats because I just don't like the way your book presents the sweating, okay? And I think I explained my rationale for that because any type of chronic condition, especially really chronic immune compromised conditions like cancers and even we could put like HIV and AIDS, these patients are going to have sweats. And the sweating actually comes from how the sympathetic nervous system is reacting and the immune system is reacting. Because I want you to think of it this way, the body is constantly fighting this chronic infection, okay? And so that actually will increase the metabolic activity, okay? So metabolic activity is just so increased in these individuals, which is why they're starting to sweat. It's just part of the disease process. I don't like the way your book has it like, oh, for these cancers and not the other, because that's not real world. It's not like that. You could see, some people may not have any sweating. Some people will have sweating. It just depends on how aggressive the cancer is getting at that point. Does that make sense? And also sweating at a resting state. That's why they say night sweats. Okay, it's not so much, okay, they're only sweating when they're sleeping, but it's when the body's in a resting state and they're like profusely sweating when you're supposed to be relaxed. Your metabolic activity shouldn't be that elevated if you're in the bed, okay? So that's the point they're trying to make with that. Okay, so I think we got it. I hope so. Any questions with 11? I know I tried to do a quick little overview, but I just want to make sure I answer any questions you may have just to make sure everyone's comfortable with the material. No one usually has questions in tutoring. I don't know if they're afraid to ask questions, or they just don't know what to say. That's why I like doing the tutoring online and where people type in their questions. Because people are more comfortable that way for some reason. It's like, what is it? People are more comfortable behind social media and they're more comfortable that way than like face to face. So they're more able to like, be free and expressive and type whatever. So, okay. So anyway, chapter 13, this chapter focuses on anemias and just a good way, and I'll try to write this on the board, make it easier for you, or at least the categories. Chapter 13 really can be divided into acute and acquired. Not acute, I'm sorry. Acquired and congenital. Now, the reason why I tell you to put it in this category is just for organization purposes, okay? Because not that you'll have a question and say, oh, which one's acquired, which one's congenital, although we should know that. But it's better to organize the topics this way because we have so many and you're like, okay, well, what's going on here, okay? So under acquired, when we use the term acquired, these are going to be things that are acquired in a sense where we develop them over time or due to a lack of something, okay? I think we all know overall with anemias that this is a deficiency in red blood cell count, and in most cases it's due to a lack of something that patient has, okay? So there's some sort of deficiency leading into the decreased red blood cell count. So to get started, we do have a number of different vitamin and mineral deficiencies that can fall under the acquired category. One major anemia that we all know is iron deficiency anemia. Okay, that is definitely the most common type of anemia across the board. We should know that, okay? Knowing that anemia, knowing what they're deficient in also helps you with what you're going to do for treatment and management. Okay, so you give them iron if they're missing iron, so very simple. Across the board with anemias, I think we all have an understanding of some possible signs and symptoms that can happen with any anemia, from fatigue to lightheaded feeling, and anything that has to do with decreased blood circulation, okay, and signs and symptoms that can come from that. Other vitamin deficiencies can include B9, which is also known as folate. A lot of times people just say folate. Also B12 deficiencies, okay, can lead to anemia. So we should know those particular vitamins and minerals. And I think that was it, okay. And that information I think is also, I try to put some anatomy and physiology review in the beginning to kind of help. So I don't know if it was there as well. Now, other acquired things. Anemias due to acute blood loss. Okay, so that should make sense. Well, if someone has a lot of blood loss, some sort of hemorrhaging occurring, that means that the blood and the red blood cells are not in the place where they should be, okay, in the bloodstream. So now this patient has an anemia because of that. The next thing we should think of is anemias due to renal failure. And we know with anemias due to renal failure that because the renal or the kidneys are not functioning as they should, these patients are not kicking out enough erythropoietin, which is the hormone that also helps make red blood cells. Okay, very important to know that. As I told you before, we have an entire chapter on renal failure, okay? There's a lot of things other than anemias that can happen with renal failure, so we're going to get into a lot of detail with that later, but this is one of the issues. What else do we have that's, I'll put aplastic anemia under this category, although with aplastic anemia, it can kind of go both ways. Sometimes they feel it could be congenital, it could just happen, or most cases are actually acquired. In a sense where if you read the information in the PowerPoint, the risk factors are chemotherapy, treatments, radiation, toxins, things like that. which all kind of tie into chemotherapy management. Now, just to give you a heads up, and this is, for cancer patients, I think we understand. Number one, cancer patients are going to have bone marrow suppression to begin with. So they're already going to have the decreased red blood cells and platelets and lymphocytes, okay? Now, what's going to happen is this. Now, let's say they're going for cancer treatment. That's now going to cause more attack on the bone marrow, okay? And it can lead them into what we call an aplastic anemia. Another term that was presented with this topic was pancytopenia. So when you hear the term aplastic anemia, it's basically a pancytopenia that happens here, which means that these patients are going to have a decrease in all blood cells, red, white, and platelets. So just to break down that terminology, pan meaning cross, cyto, cell, penia or enia, decrease in blood. Okay, so this is a decrease of all cells across the board. Are we comfortable with that? Okay. And again, major risk factors are going to be things that are like chemotherapy drugs, which are basically toxins, and I shouldn't say toxins, but they're chemicals, radiation, things like that, which attacks the bone marrow. Anything else acquired? Is there anything else acquired on your list? I think that may be it. Okay, so for congenital, we have sickle cell. So with sickle cell anemia, this is a congenital disorder where these patients are born with sickle cells, okay? Not to get into the whole genetics of things, both parents have to have the trait and all that. But however, when these patients now have this particular disease, they are born with now the red blood cells that are being kicked out of the bone marrow that are actually now abnormally shaped. Okay. The problem here is that this is not only going to cause issues with blood flow and circulation, but this can now cause an issue with how hemoglobin is also being distributed in the bloodstream. There's other congenital that are pretty similar to this as well, like thalassemia. And hereditary spherocytosis. Okay, so to save the details, I'm going to try to explain these all together. Basically, these patients are born with a congenital defect of their red blood cells, in the sense where the red blood cells are not formed properly. Okay, if it's not formed properly, the big picture here to understand is that most likely there's not going to have the proper hemoglobin and the proper hemoglobin and oxygen carrying capacity in the blood as they should. Okay, so that's the big picture. I'll get into more further details when we have class, okay, in an hour. But I just want to explain the big picture overall. Now, something else we have. Oh, glucose 6-phosphate dehydrogenase deficiency. And I'm just going to abbreviate it. What's the abbreviation? G6 DP DD. Is that right? G6D DPD. I always get that wrong. G6D PDD. DD. Okay. All right, I got it. Okay, so this is basically a condition where these patients are lacking, they're born with a missing, or I should say a lack of the enzyme that's going to help make these red blood cells. So they do not have the glucose 6-phosphate dehydrogenase, okay, to help with that. And there's also an area of hemolytic diseases of newborn. And with this condition, these babies have a situation where their red blood cells are destroyed. Okay, where and this kind of correlates with, remember how we discussed in chapter 10, yes. I can't get the name out. I don't know why I'm like,
RH factor.
my brain is not working right at this moment. I don't know why. And it's crazy because I actually start my class at 5:30, so I'm just starting work. But my brain isn't working. So anyway, the condition where the moms are Rh negative that will build up antibodies against the baby, what is the term from chapter 10? Maybe you guys can help me since you memorized it. What's the condition? Nobody knows. Hope it's not on the quiz tonight. That's not the name of the condition. The name of the condition, it'll come to me. But anyway, the mom builds up antibodies against her own baby.
Erythroblastosis?
Thank you. Erythroblastosis fetalis. I know it's a strange name. Erythroblastosis fetalis. Erythro for erythrocytes, which are red blood cells. Okay. Blastosis. Okay. This increase of breaking it down. So basically, this correlates with this under here. These babies have their red blood cells being destroyed, okay, because the mom actually has antibodies against the baby that's breaking these cells down.
This is after they're born? Of newborn? Yeah, they're born, right?
Hemolytic diseases of the newborn. Okay, so this can be developed not only in utero but also when they're born as well. So it just depends on how destructive it can be. Now let me just explain. This condition is usually not common. I just want to explain that overall. So I don't want you to think that this is something you're going to see all the time. Your books always bring it up, okay, because we have to know about it. This never really gets to this point because as long as the moms are getting proper prenatal care, it's not going to get to this point. Okay, so I just want to make you aware of that. It shouldn't get to this point if they're getting prenatal care. Because usually they'll have blood work done, they'll know what their blood type is, they'll know what's happening, they'll know the patient's history, they'll be able to give them the ROGAM injection as we said, and so that way it'll just stop all of this from happening, okay? But I just have to explain the condition. And I'm quite sure it's going to come up again when you guys take OB, okay, because you have to learn about all these disorders just in case. Okay, so that's that. So really quickly, what was also part of 13 was polycythemia. So we had Vera, secondary, and relative. So just to kind of sum this up, secondary polycythemia, a really good example would be COPD. Okay, so when patients have COPD, there's not enough oxygen flowing through the bloodstream. And what the body will do is actually kick out more red blood cells to increase the oxygen carrying capacity. A good example for relative would be dehydration. So when a patient has dehydration, there's not enough fluids that are in the body. Okay, we all know, and I explained this earlier, the fluid and blood balance. Okay, so fluid and blood goes hand in hand. So if these patients do not have enough fluids, well, the body's way of actually managing that or trying to compensate is to increase the blood volume, okay, by kicking out more red blood cells. It can't, increase fluids or make the person drink. We can increase the thirst center and make them drink more, but that's really not how the body's going to, compensate. It'll compensate by increasing more blood volume. So therefore, we can overall increase more body volume, which will balance the fluids, okay? So that's the goal for that one. Polycythemia Vera is going to be a situation where patients will increase red blood cells, okay, just kind of idiopathic. They don't know exactly why, but they just start kicking out more red blood cells. Sometimes they feel it can come from certain conditions or, you know, certain side effects of things, but most cases, from my understanding, it's just one of those idiopathic things where it just starts to increase for whatever reason. And that's that. 14, just kind of looking at my time here, because there is another class in this room. There are certain things that I did have on the outline that I told you. I was very, very specific in what I wrote on that outline. So just to confirm, it is very important to know everything about how we would screen and test for a patient that has a bleeding disorder. Okay, so I put a lot of emphasis on that. So we should know as far as like their medical history, like, you know, if the patient has a history of cancers or liver disease, you know, things of that nature. We should also know medication history. So like if these patients are on blood thinners, do they take aspirin? We should also know the laboratory testing that could be performed or should be performed, like blood clotting assessment, okay, like APTT, PTINR, bleeding time. So what I'm looking for here is making sure you know the functions or what those tests are used for. I'm not looking for numbers. I'm not testing you on numbers. That's not necessary at this point. But we need to know what the test is used for. Okay. As far as conditions, this chapter can also break down into acquired and congenital. As far as congenital, I put a lot of emphasis on hemophilia. And I think I said that in the outline. I typed that in the outline. And DIC, very important to know that one as well. Even though that's more of an acquired issue, okay? DIC is when patients have bleeding, excessive, and then all of a sudden the body is trying to clot just as fast as it's bleeding. Bleeding, clotting, simultaneously. And it is an issue, okay, because in essence the bleeding is not controlled, okay, which is why this whole thing is happening. What else? I think that was it for 14. I don't have a lot of questions for 14. Because a lot of bleeding issues are acquired. A lot of bleeding issues are acquired. Okay. So for 15, yes?
I seen thrombocytopenia.
Oh yeah, so thrombocytopenia is a decrease in platelet count. Okay. So let me just quickly go over the terminology. And that's a good thing to bring up. So when we have, and I'll go over all the emias. Okay. Leukopenia is a decrease in white blood cell count. Thrombocytopenia is a decrease in platelet count. Anemia is a decrease in red blood cell count. Okay, now you may not hear the term erythrocytopenia, maybe, but usually they just categorize that as an anemia. Okay. Then we have pancytopenia, which we know is everything. Okay, so those are all the emias. Now, thrombocytopenia is a decrease in platelets, and that situation can develop from a number of different things. Okay, so sometimes that can happen when patients have certain liver diseases. They don't make enough coagulation factors and maybe not enough platelets being secreted. Sometimes people can have that because they have an underlying disease, like not only liver, but maybe a cancer too, or if they're on cancer treatments, it can cause a thrombocytopenia. So usually when a patient has a thrombocytopenia, there's a reason for it. There's something underlying that's leading to that. Does that help? Okay, so for 15, this chapter focuses on blood flow disorders. So as I wrote in the outline, there are certain concepts that I'm focusing on. So arterial blockage versus venous blockage. So arterial blockage is when we have a blockage in blood circulation that's getting systemic. So if you block blood flow systemically, this is going to cause a patient to have ischemia. Ischemia is a decrease in blood flow to organs and tissues, which is exactly what's happening systemically, okay? If you have a venous blockage, blood in the vein is doing what? It's trying to bring blood back to the heart, okay? We know that from anatomy. So if there's a blockage in venous circulation, this can actually lead to what we call edema. Because what will happen here is that this will now start to cause blood to pool a little bit. It will change the vasculature in a sense where it can increase now a little more permeability because of that fluid building up, or I should say blood building up, and this can cause now interstitial fluid to build up, causing what we call edema under the tissues. Thrombosis versus embolism. Thrombosis is a stationary clot. Embolism is a clot that breaks off and gets dislodged elsewhere. And the other conditions that I told you to focus on in detail, these conditions, DVT or varicose veins, you should know everything about that because the chances of you seeing that is very high, okay, if you haven't heard of it already. Aneurysms, we should definitely know about that. Berger's disease and Renal's, we can compare and contrast those very easily. And then lymphedema is just a backup in lymphatic fluid, okay? The other conditions I'm going to go into more detail with when we have class at 5:30, okay? And I'm sorry, I have to kind of stop right now. Just keep in mind, my review is more extensive than what I just gave you at 5:30, okay? So it took me quite some time to get through it. So you'll hear it again.